Good evening, everyone. It's a great pleasure to have you all here. I'm Dr. Omkaro, working as a medical advisor at Retro. Our topic of discussion for today is Experience Sharing Program on Managing Postpartum Hemorrhage. The purpose of today's meeting is to have a better understanding of the postpartum hemorrhage and the role of carbetocin in it. Before commencing, I would like to introduce Hetero as an organization to you all. Hetero is currently serving in the healthcare industry since more than 25 years. It has more than 300 products in its portfolio and has an employee size of 21,000 globally. It is also the largest manufacturers of ARVs, API, and FDF in the world. It has 36 state-of-the-art manufacturing facilities and has its presence in more than 126 countries. Hetero also has Asia's largest API manufacturing facility at Visakhapatnam in Andhra Pradesh. The aims of Hetero include striving to fulfill unmet healthcare needs and reaching to customers across India. It also has wide product range encompassing multiple specialties. Hetero has a distinction of bringing 4 biosimilar products to market within 5 years of initiation. Now, I would also like to introduce our speaker for today's meeting, that is Dr. Nitin Patel, sir. Sir is currently working as a consultant obstetrician and gynecologist at Dr. Patel Maternity and Nursing Home in Nashik. He is also honorary consultant at Cantonment Hospital in Nashik. His special interests include high-risk pregnancy management and NDVH. So with this, I welcome you, sir, and hand over the session to you.
Thank you, sir. Today we are going to talk on the injection carbetocin, which is used as a drug to prevent the postpartum hemorrhage. So our talk begins with the first we will just theoretical part of postpartum hemorrhage. So the postpartum hemorrhage is defined as a loss of at least 1000 ml of blood coinciding with the signs and symptoms of hypovolemia within 24 hours after delivery of the fetus or intrapartum loss. So as you can see on the slide, PPH is common and occurs even in women who are not at risk. PPH is the leading cause of the maternal mortality in low-income countries and the primary cause of nearly half quarter of all the maternal deaths globally. Next. So coming to the causes of PPH and the maternal mortality, leading cause of maternal mortality accounting for about 35% of all the maternal deaths, hemorrhage. So all of you know that maternal mortality rate in developing countries was 240 per 1 lakh live births compared to 16 in developed countries. So global PPH scenario, if you see, 14 million women suffer from PPH. Incidence of PPH is reported as 2 to 4% after vaginal delivery and 6% after cesarean section. Next, please. So if you see the etiology of the postpartum hemorrhage, all of us know there are 4 T's which causes the postpartum hemorrhage. That is tone, thrombin, trauma, and tissue. The most common cause is atony, uterine atony. When the tone of the uterus is does not go to the prepartum state. Uterine atony, it is the inability of the uterus to contract, which may lead to the continuous bleeding. Second most common cause is thrombin, that is coagulation failure, coagulation disorders. Third most common cause is trauma, uterine trauma, that is injury to the birth canal from the, like uterine rupture, uterine inversion, or lacerations of perineal tear, perineal lacerations. And the fourth common cause is retained placenta, that is retained tissue, retained placenta or retained membranes or retained clots inside the uterine cavity. So these retained tissue, they prevent contraction of the uterus and that causes postpartum hemorrhage. So 4 T's causing PPH, out of which tone is most atony, uterine atony is the most common cause. Next. So clinical findings depends upon the amount of the blood loss. There are degrees of the depending upon the amount of the blood loss. There are degrees of the shock. First is compensated stage. Then comes the mild shock, then moderate and severe. Whenever there is a blood loss from ranging from half a liter to 1 liter, it is generally compensated by the body. So there is no change in the blood pressure. Little bit palpitations or dizziness or tachycardia may be there. When the blood loss goes from 1 liter to 1.5 liter, that is 15 to 25% of the total blood volume, then there is slight fall in the systolic blood pressure. Systolic blood pressure may range from 80 to 100, and there are patients may have weakness, sweating, and of course tachycardia. In moderate shock, the blood loss is generally between 1.5 liter to 2 liter, that is 25 to 35% of the total blood volume. There is a marked fall in the systolic blood pressure. Blood pressure may fall to 70 to 80 millimeter of Hg, and patient will have restlessness. There will be visible pallor, and of course, if you are monitoring the urine output, there will be oliguria. And the most severe form of the shock is when the blood loss is more than 2 liter, where there will be systolic blood pressure will fall up to 70 to 50 to 70. Patient will have collapse. Patient will have air hunger and anuria. Next. So how you will approach the patient with the PPH? First and foremost, you will have to check for the uterine tone. The findings in the patient with atonic PPH will be that uterus will feel relaxed, uterus will be boggy and soft on the palpation. The fundal height may be above the umbilicus if uterine cavity is filled with the blood. Investigations will show of course fall in HB. Patient will you will have to do the coagulation profile, and urea and electrolyte investigations will be done. If patient is not responding to fluid and blood replacement, then abdominal ultrasound we have to do to exclude the uterine rupture and intraperitoneal hemorrhage. Management is of course uterotonic agents. First and foremost is oxytocin, then prostaglandins, ergoid alkaloids. And if this fails, then uterine balloon tamponade. And the last and foremost is the surgical measurement measures. If the cause is traumatic PPH, of course on examination you will see the bleeding coming from the genital tract. So you will have to rule out the causes like uterine rupture, extension of the uterine angles during LACS, and of course extragenital causes such as subcapsular liver rupture or rupture of the ovarian or splenic vessels. Investigations, inspection, you will have to thoroughly inspect the vaginal canal, birth canal under anesthesia, and if required, you may have to do the sonography to identify the fluid in the patient with uterine rupture. Management is of course surgical. You have to repair the genital tract trauma, and in some cases pelvic arterial embolization may be required, such as the broad ligament hematoma or supralevator hematoma. If the cause of the postpartum hemorrhage is retained tissue like retained placenta or retained membranes, then you will have to do the manual removal of placenta and membranes under anesthesia. And if the cause is coagulopathy, then you will have to correct the coagulopathy by giving immediate replacement of blood and blood products, and surgical treatment may be required if it is unresponsive to the medical management. Next. So what is the rationale for the development of the carbetocin, which is a new heat stable formulation? Carbetocin is available in a room temperature stable formulation and convenient while presentation. It is not needed, there is no need for refrigeration. While as if you compare with the oxytocin, then oxytocin and the ergoid alkaloids, they should be kept in refrigerator to avoid the degradation. Heat stable formulation of oxytocin is currently not available, and previous formulation of carbetocin they have to be stored between 2 to 8 degrees Celsius. Resource poor countries like India, they do not always have the cold chain transport system, and so there are storage. So the storage capacity they may not be there. So what are the advantages of carbetocin, heat stable carbetocin? That is, it is stable at room temperature. It has a shelf life of 24 months at 30 degrees Celsius and 75% humidity. It avoids need for cold chain storage and logistics, and it is provided in a while. Next. So what are the different uterotonic agents we have with us? They are oxytocin, carbetocin, ergometrin, symptometrin, and misoprostol. Time of administration. Generally, we at the crowning of the baby or at the delivery of the anterior shoulder. Prophylactic use is for the prevention of PPH, which is also called as active management of third stage of labor. And therapeutic use when you use the drug for the management of PPH. Next. So here they have given you the chemical formulation, how it is different from the oxytocin. Carbetocin was created by making several modifications to the oxytocin structure, which prolongs its half-life and it reduces the enzymatic degradation. So it is a synthetic, long-acting analog of oxytocin. Therapeutic indications are prevention of postpartum hemorrhage due to uterine atony, and how it should be administered slow IV 100 microgram. The one vial contains 100 microgram of carbetocin in 1 ml solution for injection. Next. So here you can see the comparison between the oxytocin and the heat stable carbetocin. While oxytocin is a synthetic cyclic peptide form of the naturally occurring posterior pituitary hormone, oxytocin binds to the oxytocin receptors in the uterine myometrium, stimulating the contractions of the uterine smooth muscle by increasing the sodium permeability of uterine myofibrils. Whereas the carbetocin is a long-acting synthetic analog of the oxytocin with agonistic properties. It also binds with the oxytocin receptors in the uterine smooth muscle, but it causes the rhythmic contractions of the uterine muscles, thereby increase frequency of existing contractions, and there is increased uterine tone. About pharmacokinetics, all of we know oxytocin is given IV intravenously, almost immediate action with the peak concentration after 30 minutes. It can be given intramuscularly, where there is a slower onset of action taking 3 to 7 minutes, but it produces a longer lasting clinical effect up to 1 hour. Half-life is very short, 1 to 6 minutes. But in carbetocin, there is advantage. It is given IV sustain. If you give IV, there is a sustained uterine contraction within 2 minutes, lasting for about 6 minutes, and followed by rhythmic contractions for 1 hour. You can give it carbetocin IM also, which causes sustained uterine contractions lasting for about 11 minutes and rhythmic contractions for almost 120 minutes. And the major advantage of carbetocin is its half-life. You can see it is 40 minutes as compared to just 1 to 6 minutes of oxytocin. So storage and transport, as all of you know oxytocin requires a protection from the sunlight, and it should be stored between 2 to 8 degree continuously to preserve its activity. Whereas heat stable carbetocin can be stored up to 30 degree, that is room temperature. So clinical indication, all of we know oxytocin is used for the induction of labor as well as augmentation of the labor and prevention and treatment of PPH. In all four indications, it is used for induction of labor, for augmentation of labor, as a preventive measure of PPH, that is active management of third stage of labor, as well as treatment of the PPH. When the PPH is there, you can use it. But in carbetocin is indicated only as a preventive measure for postpartum hemorrhage. It should not be used for any other indication like induction of labor or augmentation of labor. And when there is actual PPH is happening, you should not use carbetocin. You should go to other drugs. So it's mainly used for the prevention of PPH, that is active management of third stage of labor. Next. So they have done a study, Carbetocin hemorrhage prevention, the largest clinical trial in the prevention of PPH, where they have taken 30,000 women across 10 countries, including India. And the outcome was the proportion of women with a blood loss of at least 500 ml or the use of additional uterotonic agent, the proportion of women with blood loss of at least 1 liter. Next. So you can see in this chart that carbetocin is very effective in reducing the blood loss. And also the safety is very good as compared to oxytocin. The frequency of blood loss of at least 500 ml or the use of the additional uterotonic agent with carbetocin was proven to be non-inferior versus oxytocin. The use of additional uterotonic agents, interventions to stop bleeding and adverse effect did not differ significantly between the two groups. So conclusion is carbetocin was non-inferior to oxytocin for the prevention of blood loss of at least 500 ml or the use of additional uterotonic agent. Next. So there is the same study they have mentioned for women who undergo a cesarean section, carbetocin resulted in a statistically significant reduction in the need for therapeutic uterotonic compared to oxytocin. Also, carbetocin is associated with less blood loss compared to symptometrin in the prevention of PPH for women who have vaginal delivery and is associated with significantly fewer adverse effects. Next. So guideline and recommendations, there are different societies, different experts groups like Association of Obstetrics, Gynecological Society, like many, there are many expert groups who have recommended the carbetocin. As you can see in this slide, WHO in 2018, the only one they have recommended for prepaid prophylaxis, oxytocin, carbetocin, misoprostol, ergometrin, oxytocin and ergometrin fixed dose combination. Any one of these, only one. Similarly, the Canada Society has recommended carbetocin. FIGO has also recommended that carbetocin is one of the recommended agent for PPH. Actually, it should be prevention, not management. Germany and France also. Next. So here I would like to share with you one interesting case. This lady was primary gravida, 39 years old, elderly, IVF conception, 37 weeks of gestation, DCDA twin with gestational hypertension. She was posted for elective LACS. So injection carbetocin 100 microgram was given as slow IV bolus after delivery of the second twin, and uterus was very well contracted and there was no PPH in this case. So this is a interesting case I would like to share with you. You can see in this patient, which she was very high risk for atonic PPH, being a twin gestation plus mild gestational hypertension, elderly gravida. Still, with only one dose of carbetocin 100 microgram IV given after the delivery of second twin, uterus was very well retracted and contracted, and that remained contracted almost throughout 6 to 12 hours post-operatively, and no need of any additional drug was given for this patient. So it's carbetocin is an excellent drug for the prevention of postpartum hemorrhage in, you can say, all the cases, but especially in high risk patients where you are anticipating atonic PPH like polyhydramnios, twin gestation, anemia, patient with anemia, previous history of PPH, like that. So that's it. I would just like to conclude that as compared to oxytocin, carbetocin is a very good and effective drug for prevention of postpartum hemorrhage. The advantages are first and foremost that is it is stable, heat stable, so you can store it at room temperature at 30 degrees Celsius. So it does not require any cold storage. Secondly, it has a high, longer half life. The action is much more prolonged, and because of that we don't need any extra uterotonic agent once you have given carbetocin. That is the most important, and I will say the beauty of this drug.
Okay, okay. Thank you. Thank you so much, sir, for sharing your valuable insights. It was such a wonderful session, and also the case that you have shared. It was also very informative. Now we move forward to the next part of our session, that is panel discussion, where we will be having frequently asked questions and some real world scenarios. So, moving to the first question, sir. So, considering the use of carbetocin as a first line drug to prevent postpartum hemorrhage, what are the specific advantages or benefit does it offer considering its use as a first line agent?
Just now I have told you that first and foremost is the storage conditions. It does not require any cold chain storage, so it's very good drug for the use in the tropical countries like India, where chain may not be effective, may not be there all at periphery or at the remote places. Second is longer half life, so the action is prolonged, and because of that you rarely require any additional drug. And third is safety. The only contraindication they are given is that hypersensitivity to the drug, or very severe cases of PIH, severe cases of cardiac disease or hepatic failure, like that only. Very few contraindications. Otherwise, it is very safe.
Okay, okay, okay. Thank you, sir. Moving to the next question. So, you have already described this, sir. So, patient profiles in which basically we can anticipate PPH. So, any
Yes,
additional
the
comments?
person which are high risk for developing postpartum hemorrhage are the patients where you know that uterus is not going to contract as it should contract after delivery. So, what are the such cases? First and foremost is the multiple gestation. That is twin and triplet pregnancy, where uterus is excessively enlarged, and so it takes time to retract. Secondly, polyhydramnios, previous LACS, anemia, PIH, all these cases are where you will anticipate postpartum hemorrhage.
Okay, okay. Moving to the next question. So, doctors generally use oxytocin for labor induction. So, sir, in the same patient in such scenario, can doctor use carbetocin for prevention of postpartum hemorrhage?
Yes, you can use, because as we have discussed that oxytocin is a very short acting drug. It has a half life of just 1 to 6 minutes. So even if the patient has received oxytocin for labor induction, by the time the patient delivers, that drug is already washed out, and the receptors are no longer occupied by the oxytocin. So you can use carbetocin, but never
Okay.
vice versa. If you have given carbetocin as a preventive measure for PPH, and if patient develops postpartum hemorrhage, then you can't use oxytocin, because the receptors will be blocked by the carbetocin, because it's a long acting.
Okay, okay. It's because of its half-life, it will be already in the
Yes,
body. It will be already in the circulation.
yes, 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 yes.
Okay, okay. Moving to the next question, sir. So, as IV route is the preferred route, are there any case scenarios or patient profiles in which IM route would be preferable?
Generally, the IV, most of the patients for the LACS and as well as for the normal delivery, IV line is already secured. So we prefer IV route only. But if suppose IV access is not secured, in very emergency patient came with full dilatation or like that, in that case you can use IM route also. But generally
Okay,
we prefer IV route.
okay. It's convenient and the preferred route. IV route is
Yes,
the preferred one. Yes.
yes, it's prefer route.
Okay, okay. moving to the next question. So you have already described, sir, that it is very much safe. Any additional comments that you would like to add on this, considering the tolerability of carbetocin?
It is very well tolerated. The side effects are very minimal, like flushing, a little bit abdominal pain, nausea, vomiting. That's it. Otherwise, it is very well tolerated. Contraindications are only history of any hypersensitivity or anaphylactic reaction to the drug, or severe migraine, severe cardiac disease, hepatic failure, severe migraine. These are only contraindications. Otherwise,
Okay,
it is very safe and it is
okay,
very well tolerated.
okay. Sir, the side effects that you mentioned, considering gastrointestinal side effects, so are they short-lived or they persist for some duration?
Mm, in my case, actually, personally, I have not come out
Observed. Okay.
any any side effect, but they may. I don't think they are. They may be.
Because the half-life is also short.
Hmm.
Okay. Moving to the next question. So, sir, if patient is not responding adequately with carbetocin, then in order of preference, which additional uterotonics would you use?
Yes, there may be scenario very rarely that you are given carbetocin as a preventive measure and still patient lands up into postpartum hemorrhage. In that case, I preferred carboprost,
Okay, okay,
or you can use misoprost also, tablet misoprost, or you can use injection methargin also, ergometrin.
okay. Thank you, sir. Moving to the next question. So, you have already described all the advantages of carbetocin over other uterotonics. Any additional comments on this question, sir?
The most, I think, the advantage is action. The action is so prolonged and sustain action, because it causes the rhythmic contractions over a period of almost 1 hour. So the action is very much sustained. So the critical period of immediate post delivery, that is covered. That is most important, which is not there with the oxytocin. Oxytocin generally, after most of the cases, after few minutes, patient may have atony and patient may land up in PPH. Once the
Okay,
oxytocin effect, it when it is washed out.
okay. Thank you, sir. So, moving to the next question. So, can carbetocin be kept as a reserve drug or it should be used as a first line drug? So, you have already mentioned on this.
No,
Any
we
additional?
are using it as a first line drug now for all the elective and emergency LACS. For vaginal birth also, I think you can use it as
Okay,
a first line drug.
okay, sir. So, coming to our last question, sir. So, if you have to summarize your experience of carbetocin, its efficacy and safety, and when it should be preferred, so what would you summarize and your comments to our delegates?
So the take home message is carbetocin is now preferred as a first line. I will say first line drug for the active management of third stage of labor, that is prevention of PPH, because it is heat stable, that is stable at room temperature. It is long acting, and once you use it, there is hardly any other drug which is needed after that.
Okay. So, thank you, sir. So, this brings us to our end of our session. So, thank you so much for sharing your valuable insights and guiding all of us regarding the efficacy and safety of carbidocin, its use, its advantages, and sharing your experience as well. So, I would also like to thank all the delegates for their participation and engagement into the meeting. So, again, thank you, sir. This marks the end of our meeting, and we can close the meeting now.
Yes, thank you. Thanks a lot. Thank you.
Yes, thank you, sir.
Thank you so much, sir, for such a wonderful